Hi everyone. Today I will talk about a topic that is very close to my heart, and that is that we are currently distorting general practice by sacrificing patient care for prevention. My name is Minna Johansson. I work 50% as a GP in a small town in Sweden and 50% as an associate professor at Gothenburg University. I have no financial conflicts of interests. We GPs would need to work 27 hours a day to follow all guidelines that apply to our patients. Every day we face a tsunami between what is expected of us and the time we have to care. And this leads to inefficient care because we do not spend our time on the interventions with the greatest benefit or importance to the individual. It also leads to unequal care because we do not spend our time on the patients with the greatest care needs. And it leads to ethical stress and burnout amongst us clinicians. If we would follow guidelines, massive opportunity costs would substantially limit access to high quality care. And in this context, it's not so strange that many of us working at the forefront of medicine desperately argue that we need more resources. But at the same time, most high-income countries have never spent a greater proportion of our resources on healthcare. In Spain, healthcare spending has risen from 3% of GDP in the 70s to 7% in the 90s to 10 to 11% today. And the number of doctors per capita has increased by almost 50% in the last 20 years. This has some natural explanations, of course. We have an aging population who needs more healthcare and lack of advancement than we had in the 70s. But another reason that receives much less attention is an expansion of medical territory. And to illustrate this, I will use the analogy of the public health river. In short, the analogy is that downstream in the river, people are ill and have symptoms. They are drowning and therefore needs healthcare to save them. And this is where healthcare has traditionally spent most of our efforts. However, in the last decades, medicine has expanded our efforts further and further upstream. And the idea is that by preventing disease instead of treating it, we could avoid suffering and save healthcare resources. And this all sounds very intuitive, to treat the causes of the causes instead of the symptoms. But this is the public health river, and when medicine, with our individualistic and biomedical lens, goes upstream in the river of public health, we end up in a lot of problems. This is an example from Norway. In this study, authors applied the European guidelines for cardiovascular disease prevention to the general population, and according to the guidelines, over 80% of all Norwegian adults need to see their GP to reduce their cardiovascular risk. The authors also estimated that 99 GPs per 100,000 adults would be needed to follow the attention only. And the problem was that there were only 87 GPs per 100,000 adults. So in other words, if we GPs try to prevent cardiovascular disease for 80% of the population we serve, people who are ill and in greater need of medical attention will inevitably forgo care. And one of the major explanations to this absurdity is that for most risk factors and conditions, the cutoffs for what is considered sick has been continuously lowered during the last decades. This is true for osteoporosis, hyperlipidemia, depression, anxiety, neuropsychiatric diseases, asthma, COPD, and many more conditions. This is the latest guidance from the US, where the new cutoff for hypertension is 130/80. And the problem is that since blood pressure is normally distributed in the general population, lowering the cutoff from 140 to 130 would double the number of blood pressure patients. There are simply many more people with a blood pressure between 130 and 140 than there are people with a blood pressure between 160 and 170. But the benefits from reducing blood pressure from 170 to 160 is much larger than the benefit from reducing blood pressure from 140 to 130. And this dynamic is true for most risk factors and conditions. So in other words, the constantly lowered cutoffs across virtually all medical fields make us prioritize patients who benefit less from care at the expense of patients who would benefit more from care. Medicine expand medical territory even further upstream and try to improve public health by changing our patients' lifestyle. In this study, we found that NICE in the UK made 379 recommendations for clinicians to change their patients' lifestyle. Only 3% were supported by high or moderate certainty evidence that they help people change behavior or had any beneficial effects. And to follow all these recommendations would require more doctors of all specialities and 5 times as many nurses as currently working in the NHS in the UK. If you're interested, check out our paper in the Annals of Internal Medicine on this topic. But medicine go even further upstream. The new trend is that GPs should prescribe time in nature or singing in a choir, or for their patients to spend time with other people. The Royal College of General Practitioners in the UK write on their website that loneliness has become a public health epidemic, that it is as bad for health as obesity, and that GPs do not only have a key role in identifying people who are lonely, but also those who are at risk of becoming lonely. And of course, I'm not questioning that loneliness is extremely important for health, but it is highly unlikely that the most effective and feasible strategy to reduce loneliness in the population is for me to target one of my patients at a time in my office. And if we zoom out, this can also be questioned from a more philosophical perspective. Is it really a good idea to define everything in lives in terms of medical risk reduction? Should we spend time with other people to reduce our cardiovascular risk, or should we do it because it brings fundamental meaning to our lives? Some time ago, I was at the hairdresser and read one of those glossy magazines, and it said that sex lowers cholesterol. And I thought that was really funny because, I mean, I don't know about you, but I find it hard to imagine a more boring reason to have sex than the lipid lowering effect. There are some things that medicine should just stay out of. The problem is that healthcare is actually not that good at prevention. The key determinants of health are not what happens within healthcare. Health is determined not so much by what doctors do for patients, but by arrangements in society. And this is an example illustrating Michael Marmot's point. Screening for lung cancer is estimated to save 12,000 of the 160,000 lung cancer deaths every year in the US. And this might very well make screening worth the effort. But at the same time, community-oriented interventions to decrease smoking is estimated to save more than 10 times as many lives, and is also much cheaper and has less potential for harms for the individual. Every euro we spend on healthcare could be spent on schools, social welfare, or bicycle paths. And this has a much greater impact on public health, and increased spending on healthcare may actually not be beneficial for public health. So back to the river of public health. Healthcare is going upstream, and this is all done with the best intention. But when medicine go upstream, we do this by applying an individualistic lens to public health issues, and the consequence is flooding. The thing is that we are quite good at caring for people with symptoms. Our care is quite efficient for people who are downstream and already ill. For example, this study from Canada found that we only need to treat 5 people with acute symptomatic conditions to improve patient-important outcomes for 1 person. And we only need to treat 7 people with long-term symptomatic conditions to improve the outcome for 1 person. But for cardiovascular disease prevention, we need to treat 40, and for cancer screening, 1,000. And for social screening and health promotion, the number needed to treat is even higher. And this means that if we focus our efforts downstream, we need quite few clinicians to care for all the people that need our help. But the further upstream we go, the more we expand medical territory to include larger and larger swaths of the general population, and at the same time our medical interventions become less and less effective, so the number of clinicians needed increase almost exponentially. And I argue that today we are following all the guidelines and quality metrics upstream, so we let people who are downstream drown. Applying the individualistic lens of medicine to public health is inefficient, expensive, and harmful. And just to be clear, I am not arguing that upstream issues should not be targeted. On the contrary, social equity and flourishing is absolutely crucial for public health and well-being. But I am arguing that we should leave public health issues to those who do public health best, and that is the community. And we should do what healthcare does best, and that is care for individuals who are ill and prevent disease in those with the highest risk. Also, I am not arguing that we should not do prevention at all, but individually oriented prevention efforts within healthcare should focus on a small proportion of the general population with the highest risk. If you're interested, check out our recently published paper in BMJ on this topic. And finally, to achieve a sustainable healthcare, we must learn to prioritize the patients with the greatest care needs and the greatest benefit from healthcare. It is time for GPs to take the lead. Thank you so much for listening. Bye.